Welcome to the Healthy, Wealthy, and Smart podcast. Each week, we interview the best and brightest in physical therapy, wellness, and entrepreneurship. We give you cutting-edge information you need to live your best life, healthy, wealthy, and smart. The information in this podcast is for entertainment purposes only and should not be used as personalized medical advice. And now, here's your host, Dr. Karen Litzy.
Hey everybody, welcome back to the podcast. I am your host, Karen Litzy, and today's episode is brought to you by NetHealth. They are creators of a new online rehab community designed for the intersection of the clinical and business sides of rehab. It's the Rehab Therapy Operational Best Practices Forum. It's all about habits and initiatives that juice up your attendance, revenue, workflows, documentation, compliance, efficiency, and engagement while allowing your provider teams to keep their eye on the prize, their patients and outcomes. I personally believe that a better connected rehab therapy profession has the power to help more people. So jump in, subscribe, and join the conversations today. You can find the Rehab Therapy Operational Best Practices Forum at www.nethealth.com/healthy. And again, you'll see stats on community members already involved, polls, write-ups, white papers, surveys, benchmarking calculators, videos, podcasts, and more. So go to www.nethealth.com/healthy. All right, now on to today's program. I'm so happy to welcome to the podcast Dr. Elaine Lonnemann. So Dr. Lonnemann is the current president of AAOMPT and has served 2 terms as secretary and chair of AAOMPT, International Federation of Manual Physical Therapists, Educational Standards, and International Monitoring Committee, member of the OMPT Description of Advanced Specialty Practice Task Force, and committee member and author for the 2018 revision of the Manipulation Educational Manual. She received the AAOMPT Mental Service Award and the 2017 President Joseph and Maureen McGowan Prize for Faculty Development from Bellarmine University, which provided the opportunity to study the history of manual therapy at Oxford University. She received her BS degree in physical therapy from the University of Louisville and her MS and DPT from the University of St. Augustine. She is the program director of the Transitional Doctor of Physical Therapy program for the University of St. Augustine. She was an associate professor for Bellarmine University in Louisville, Kentucky, and taught in the first professional program for 15 years. She has presented nationally and internationally on the topics of spinal thrust manipulation, low back pain guidelines, and leadership. She authored textbook chapters in orthopedic physical therapy and has published in the areas of spine morphology and joint manipulation. She is passionate about leadership, post-professional physical therapy education, manual physical therapy, and integrating pain and movement sciences in the clinical management of clients. Woo, she has done a lot. In this episode, we talk about the American Academy of Orthopedic Manual Physical Therapist position on the opioid crisis, patient health outcomes following the diagnosis of degenerative disc disease and what they think specifically of that diagnosis, the use of clinical practice guidelines for low back pain and physical therapy practice, pain science education, and the treatment of low back pain. So it was a great episode. I am so happy that Dr. Lonnemann came on the program. So everyone, if you treat patients with low back pain, which most people do, then you are going to really like this episode. So thanks everyone for tuning in. Hello, Dr. Elaine Lonnemann. Welcome to the podcast. I'm happy to have you on.
Thanks. I appreciate being here.
Okay, so today we're going to be talking about AAOMPT. We're going to be talking about degenerative disc disease. But first, I would love for you to talk about AAOMPT, what it is, why it exists, and what do all those letters in AAOMPT stand for?
Absolutely. So AAOMPT stands for the American Academy of Orthopedic Manual Physical Therapists. And it's an organization, it's an association that started in 1991, basically because some individuals felt like we needed a group that could present scholarly works, that could meet, have conferences, and also test clinicians based on international manual therapy standards. And so that group, several individuals got together, and that's how it started in Michigan, actually. So that now we represent 3,000 physical therapists.
That's a lot of therapists. And how long have you been part of the organization?
I've been a member since actually 1994, so quite a long time. I was a resident and fellow in training, and became a member really when it was beginning. So I've been involved as a member and more recently as an officer.
Awesome. That's great. So now let's talk about AAOMPT's position on DDD, or degenerative disc disease, which is something that I think is very commonly diagnosed. I think it makes people nervous when they hear it because they hear the word disease. So can you talk a little bit about degenerative disc disease and the position AAOMPT has on that?
So our position is we just oppose the use of that term. It's commonly used, as you said, and it's really used to diagnose an age-related condition, and that age-related condition shouldn't be considered a disease. It shouldn't be considered degenerative. So it happens whenever on imaging, you see changes in the shape or the size of the discs in the spinal column. So that's how it's identified. And we know several things, that nearly everyone's discs change over time. And the interesting thing about that is that not everyone feels pain even when they have those changes in their discs. So that's why we oppose it, or one of the reasons. So,
and like we said, it is so highly diagnosed, and when people hear that term disease, they think of something that, like, cancer is a disease, or Parkinson's is a disease, or a syndrome. But I think it's kind of scary terminology, and words matter. So what does AAOMPT feel should be a better descriptor?
Well, I don't know that we have a descriptor in terms of a substitute, but I think, patients really have the right to accurate healthcare information. And when, like you said, when they are given that diagnosis, not only disease puts a lot of fear in their mind, but degenerative. I mean, they start to lose hope because degenerative just sounds like, they're going down a pathway, so if it is just described as mechanical back pain or radiating back pain, and our healthcare system really tries to find a tissue or a pathoanatomic cause for low back pain. And the research clearly indicates, and has over time, that it's very difficult to find a specific cause for low back pain. So we really need to move away from that model. And, the other part of that is the patients lose fear, they lose hope, and they also begin to believe they can't manage their own pain. So they lose self-efficacy. And we know how important that is for our patients. And I think that's the one thing I love about our profession, is that we really help patients manage and control their symptoms, their condition, and improve their function. And whenever they're given that label, it can misguide them, because they lose hope. And then they might start choosing, riskier treatment options.
Right. So. Surgeries, medications, even less invasive procedures, things like that maybe may not be necessary. But like you said, if you're the patient getting this diagnosis of degenerative disc disease, it can maybe feel like you're at the end of your rope and you don't have much more to go.
That's right. And patients need to know that their situation is real, that the findings that they have, because most people are diagnosed after they've had imaging. And so I think it's really important that we emphasize, yes, those findings are real, but this isn't a disease and this can be managed. And, the other thing is that oftentimes those imaging findings stay, but their pain goes away after they're treated. So, that helps to give them some hope. I recently had a student who was 26 years old who came up to me and said, I'm really concerned. I went to see a healthcare provider, and because I was having some back pain, and they diagnosed me with degenerative disc disease, what am I going to do? And then she just went and almost fell apart. because she said, I love to run. I don't know what I should do. Can I continue to exercise? And I'm thinking about getting epidural injections because I don't want this to progress. And so I had to kind of step back for a minute and say, okay, just explain to me why you went, tell me about your pain, because she told me I'm not having pain now. She had pain for a week and then went in because her sister had structural scoliosis. So she was fearful, even though that was at 16, she was fearful that she might have a condition that would be a problem. And now she's fearful because she's been labeled as having degenerative disc disease. So, it really took a while to counsel her and, to again, affirm these findings are real. There are changes in our discs, but these are normal changes that occur with aging, and they shouldn't be considered degenerative. The studies indicate that, there's oftentimes when those findings are present, they don't correlate with the exact clinical presentation of the patient. And that's what we want to get. That's the message we want to get across.
And as physical therapists, we can certainly relay that message to our patients. But if the patient hears that from the physician first, it makes it a little bit more difficult. Our job becomes a little bit more difficult because now it makes it seem like we're giving two different diagnoses. And so how can, maybe it's AAOMPT, maybe it's the larger APTA, maybe it starts with us as individuals, but how can we, as the physical therapist who is maybe seeing this patient after they were given that diagnosis from the doctor, communicate to the physicians? Or, because this is a medical system-wide use of terminology, and it really needs to change from top to bottom. And I feel like sometimes, we're that point of entry, but oftentimes people are coming to see us after they get that diagnosis. So how do we as a profession advocate for this change to the greater healthcare system?
Well, I think we definitely need to partner with our medical colleagues, with APTA, AAOMPT, and we are already partners, but definitely get the word out that, this type of diagnosis really does misinform patients. There is research, and AAOMPT has developed a white paper that explains the research related to how this misinformation can potentially guide their treatment or lead them to choose, like you said, riskier treatment options. And, one of those, obviously, the opioid epidemic is something that we have to think about. And not to say that it's going to lead them directly into that path, but it does. There has been some research that indicates that, the healthcare costs are driven because we aren't following the clinical practice guidelines for back pain. So I think the biggest message that needs to come out is we need to follow those clinical practice guidelines. And I just heard Tony DeLito do his keynote presentation at the Interprofessional Collaborative Spine Conference, and there were physical therapists and osteopathic physicians and chiropractors all together in a room. And, it was a great opportunity to meet, as partners with them, and, what can we do for the greater good of our patients? And I think the biggest, and he actually presented some of the challenges and what can we do from here forward really to improve this situation. And he was talking to all of us. It wasn't just physical therapists, but one of the things that he did address was the continuity of care. And he said it's really important that patients don't wait, that we get them in early, and not that every patient and I want to make sure this is clear. Not every patient who has low back pain needs to be seen by a healthcare provider, whether it be a physical therapist or other conservative type of clinician. Sometimes that pain will go away, but if it's very intense and if it doesn't go away, then they should seek care, and it should be early. So he was talking about the continuity of care, in terms of who sees the patient first, and whoever does should follow the clinical practice guidelines that recognize, with some time, with some activity, with some coaching, reassurance, and a comprehensive medical exam that really does rule out a systemic cause or something more sinister, because that's the other thing patients are fearful. My 26-year-old student was fearful that this was something sinister. So I think that is a really important message to get out, that comprehensive physical exam can really help to rule out some of the medical disorders that, are uncommon in low back pain, but that our patients are concerned about. So, so continuity of care was one thing he mentioned. Oh, and the other thing he mentioned is variation in care. Of course, that's a big problem because, whatever healthcare provider you see with low back pain, there's a ton of variation in how the provider is performing interventions. So, he highlighted that, and I couldn't agree more. But one of the things that he mentioned, and of course, I'm president of the Academy of Orthopedic Manual Physical Therapy, so one would think I'm going to mention manual therapy, but really it's because that is part of the clinic. One of the recommendations of the clinical practice guidelines is manual therapy for back pain. And again, not every patient needs it, but he mentioned, manipulation, mobilization, those are forms of manual therapy along with exercise. And so I think that following the clinical practice guidelines, trying to reduce our variation in care, and also recognizing that, as physical therapists, we need to refer on, or we need to know when not to treat. And when we do treat, to treat consistently and follow those guidelines. So that's probably a long answer to your question, but as far as the message that needs to get out, I really just think highlighting those things are important.
No, and I don't think that was a long answer at all. I think that was a very good comprehensive answer. And, we're talking about clinical practice guidelines. Where can people find these clinical practice guidelines? I know the orthopedic section of the APTA has clinical practice guidelines on their website. Are there other places where people can search for these guidelines? Because oftentimes we talk about clinical practice guidelines, but people are like, I don't have any idea where to find them. I don't know where to look.
Well, so that's a good point in terms of looking at websites. I think the Orthopedic Academy, their clinical practice guidelines follow the majority of practice guidelines that are out there. The American Family Practice group also has clinical guidelines. Chow published a group of guidelines, and they're all fairly consistent in turn. There are some variations, and sometimes people ask, well, why are there so many variations? And in part of it's because the different groups, there might be some bias in those, but and that's what Dr. DeLito mentioned. Just if you break them down and look at the commonalities, again, at least for back pain, I think those are the things that you have to look at. So I know APTA has some links, and now that you mention it, we will put links on our website as well to the clinical practice guidelines that are out there. And we'll have a link to this white paper as well, that the Alicia Emerson led that charge along with Gail Dial and Dan Rohn and other Jason Silvernail, other APTA members, AAOMPT members that work in this area.
Yeah, because I think there is a breakdown from, so you graduate with your PT degree, you start working, and if you don't keep up, you don't know where to look, you're kind of just sort of floating along using maybe what you learned in school, which is great because hopefully you won't kill anybody or do major harm to somebody. But I think when it comes to diving deeper into treatment paradigms, these clinical practice guidelines, people have to be proactive about that. And
Absolutely.
So knowing where to look and knowing where to find them is great. And I also want to touch back on the variation of care. And when you're talking about variation of care, are you talking between physical therapists themselves or between a PT versus a doctor versus a chiropractor, manual therapist versus non-manual therapist? I mean, I think there is a lot of variation to care, and that can also be quite confusing to the patient. So I don't know in that keynote if he sort of touched on what he meant by variation of care.
Yeah, he meant within physical therapists or within profession, and really looking at, at all the individuals in the room. Many of us are providing very similar treat, or at least are able to provide similar treatment options. And so his point was that, we really should be looking at a more consistent care model following the practice guidelines and not varying to other types of treatment approaches that may not have the evidence. And so variation in care, but also that evidence, the care that is supported by the evidence.
Of course. And, that brings me to, this is going slightly off topic, but well, no, not really. It's still on topic. It reminds me of a post that I saw in a Facebook group of physical therapists. And it was a newer-ish grad, maybe out a year or two. And he said something to the effect, I'm paraphrasing, when we advertise to the public about what we do as physical therapists, everyone tends to say, we're evidence-based profession. He said, shouldn't the consumer already know that? And how important is it? Like, don't you just have to do what the patient wants? Because all we're worried about is our job is to make a person feel better. So what does it really matter what you use to get them there? Meaning, does it matter if you use something that's evidence-based or not?
Well, and I think, part of that is patient education and having a relationship with your patient so that they do trust you. So you have, I think they have to be able to trust you, and you have to develop that therapeutic alliance with them to help them understand that, these are treatment options and it should be patient-centered. We want to be patient-centered, and we want to help them understand that these are the best approaches, and it's not a one-size-fits-all. I mean, there are some outliers, but the extreme variation that has been shown is the problem. It's not the occasional patient who, well, yeah, sure, maybe that it's more patient-centered to do a different approach. But there's extreme variation, and I think even if we just reduce that by 50%, I think it would have a huge impact on care. And the research that's coming out of University of Pittsburgh, and I'm not involved with this, so I'm just reading and trying to do the same thing everyone else is. But there's some big research that's coming out to talk about that will speak to the, following the guidelines when there is variation of care, or if there is variation of care. How it's different.
Yeah, and I know there was a study that came out a couple of weeks ago that showed that, with different diagnoses, less than half of physical therapists actually follow best evidence to treat.
Yep.
Yeah, you're like, yep.
Yeah, it's not, and the thing that you mentioned before too is, how do we avoid that? I think, as you mentioned, APTA, or being a member of the American Physical Therapy Association, really helps me to streamline my direction of understanding. So I can go to PT in Motion. I can look at, there's a lot of great white papers that they have, physician statements, on the opioid epidemic. There's just a ton of great resources there. And it was another thing that I would emphasize for clinicians.
Yeah, because, in the end, it's you want to treat people using best evidence, and I think it was Jason Silvernail in a comment said something, again, I'm paraphrasing, but something to the effect of, why would I waste my time doing something that I know doesn't have evidence behind it, when I could be spending that time, precious time, with our patients? Sometimes you get an hour, sometimes a half an hour, sometimes 15 minutes, right?
Right.
So why would you waste that precious time on something that doesn't have the evidence behind it, when instead you can be doing something that has been shown to help? And
That's right.
And that goes back to, and then you'll hear the argument against that was like, well, the patient really wanted it. So that's how I'm developing my therapeutic alliance.
Yeah.
But I would still argue against that, and that's where, like you said, patient education comes in. You want to explain to the patient, hey, listen, I understand that you like treatment XYZ, but right now we know that treatment ABC is more appropriate for you given where you're at, and explain to them why. And I've done that plenty of times, and patients are like, okay. So,
Right.
and
And then there's an opportunity to negotiate. Let's just try this. If it doesn't work, this seems to be more effective, and it is more efficient. And like Jason said, why would you waste your time and their time? And that's what I tell the patient. I respect your time, and this is what we understand, and this is what we know at this point, and is best care. So, if you're willing to go along with me on this, I think we can try it out. And if it doesn't work, you can fire me. You can find another physical therapist, or I'll find you someone that it works, or the treatment, So yeah, I think we really have to think about that.
Yeah, and I think, like we said in the beginning, and going back to degenerative disc disease, words matter.
Mm-hmm.
Right? And how you explain things matter.
And on that note, we're going to take a quick break to hear from our sponsor and be right back. Are you interested in a free opportunity to check in with the latest thoughts of other rehab leaders? Well, I've got one for you. There's a new online rehab therapy community designed for the intersection of the clinical and business sides of rehab. It's the Rehab Therapy Operational Best Practices Forum. Catchy name, right? It's all about habits and initiatives that juice up your attendance, revenue, workflows, documentation, compliance, efficiency, and engagement, while allowing your provider teams to keep their eye on the prize, their patients and outcomes. I personally believe that a better connected rehab therapy profession has the power to help more people. Jump in, subscribe, and join the conversation today. You can find the Rehab Therapy Operational Best Practices Forum at www.nethealth.com/healthy.
Well, and Michelle Beatty just published a systematic review in spine that she looked at the term degenerative disc disease, and the name of the article is What's in a Name, and also found that there's so much variation in what healthcare providers are calling degenerative disc disease, and in summary found that it's inconclusive, and there's not evidence to support this as a disease, and there's so much variation in it that they also recommend not using it as a term.
And so we talked about from a sort of 30,000 foot view as to what associations can do to kind of help clean up terminology, this kind of medical terminology. And that may, like you said, partnering with our physician colleagues, partnering with maybe our chiropractic colleagues to kind of change the narrative. But what can, for all the listeners out there, let's say you're an individual therapist, what can you do to kind of help change the narrative around that term degenerative disc disease? So your patient comes into you, they're fraught with worry. What can you do?
I think the biggest thing is to get our patients as our advocates. And so taking the time to educate them about it and say, yes, this is real. Your changes are real. This isn't a disease, and to help them to understand that. And then give them the tools, say, hey, when you go back to your physician or your other provider, whoever referred, or maybe they didn't refer, get the word out to these medical providers, get the word out to, senators, legislators, and because they're speaking to them as well, and support this aspect of, whether it's conservative care, and also having pamphlets or educational materials, that really do talk about, if you are referred to a physical therapist first, that there's, I believe it's an 89% less likelihood for that patient to be prescribed opiates in the following year. And that's a huge statistic in terms of, and everybody's concerned about the opioid epidemic right now. So, following practice guidelines, and physical therapists should be considered, first primary contact providers. And we can do a comprehensive medical exam. We can screen. We know when not to treat. We know when to refer on. And following those guidelines, I think, is the other part of what I educate my patients about. So I would say, these are the guidelines, and having this material. So if you're interested in sharing this with other people, and there's certain patients that are more vocal than others, and whenever I hit those patients, I really get them and hit them hard and say, help share this information. If you found this valuable, please advocate for not only yourself, but for the next person that comes down the road, so they don't have to worry that they're a 26-year-old now and they have this label.
Yeah, this quote unquote disease that is not. That is not. All right. So is there anything else that, from your perspective or for AAOMPT's perspective, that we missed, that you're like, I really want, whether it be other physical therapists or healthcare providers, even the general public, to know?
I think it's important that I'm clear on this. I'm not saying that imaging isn't useful, because I've talked a little bit on the downside of it, but in the absence of trauma or any other systemic medical concern, imaging studies aren't necessary for low back pain. A comprehensive medical exam is. So I think that's something that I would like to emphasize. But there are times when imaging is necessary, and I don't want to come across as saying that we're downplaying it all the time, because sometimes it certainly is necessary. But I think that the biggest thing that people understand is that these are common age-related changes in the spine. They don't necessarily correlate with symptoms, and that's that's hard for the patients to understand, and providers, because we are so focused on finding, some type of pain generating tissue as the cause. So sometimes I'll share stories too with patients and say, if I, because they've now got this disease, they've got imaging, they've got findings, and you have to kind of talk them off the ledge to a certain extent. And I say, if I had a group of 20-year-olds, 100 20-year-olds in a group, and then I have a group of 80-year-olds, 180-year-olds on the other side of the room, and none of them have back pain. Now, they may probably, 90% of us have back pain at some point in our life, but at this point in this room, none of them have back pain. But then if I sent them all into the MRI or imaging room, then 37% of those 20-year-olds would come back with degenerative changes in their spine, or positive findings. And if you then look at the 80-year-old group who then goes in and has the MRI, that number goes up to 96%. So that kind of gives them a little bit of a balance. So I guess that's the other thing I would share, just that these findings on imaging don't necessarily have to lead individuals to go down a path for riskier treatment options.
I think that's a great statistic, and thanks for sharing that, because now that's something that if there are any therapists listening, they can kind of use those statistics to say, hey, listen, this is common as you get older. And I think, the downfall that I can see from having this conversation with the patient is then the patient saying, so you think it's all in my head?
Right. And that's why I emphasize,
no,
it's real.
It's real. Yes.
Yeah.
So that's why I'm glad that you said, listen, your pain is here. It's real. You're experiencing this. This is not made up. But let's see if we can, like you said, follow these guidelines, get you to move, do exercise, feel more comfortable in your body in order to help reduce your symptoms, reduce the pain. Because when in my early days of explaining things like that to patients, I've had someone say, so it's all in my head. And I was like, oh, that is not what I meant. I definitely screwed that up. And with experience, you learn, right? You learn how to do that better. You learn how to relate to the patient. And the best thing to do, like you said, is to use stories and to use statistics and to use metaphors and things like that, so that people can kind of understand where you're coming from. But yeah, that's the only downfall that I could think of. That someone playing devil's advocate here, right? That's
absolutely. Yeah. And I think as physical therapists, we have to kind of get outside of ourselves. Yes, we know that pain is, it may begin in the brain and the synapses and all of that, but do we really have to say that specifically to the patient? Can't we just say, It's a normal, natural, physiological response. You have it. What you have is real. And it's impacted by a lot of things. It's a complex issue, but what you have is real. And I've never argued. That was probably some of the best advice I learned in my fellowship training. When the patient has pain, and this was way back when, before a lot of the pain science researchers came out, but when the patient says they have pain, it is their pain. That is what they have. And you don't argue with them about that. Regardless of what type of physiological response you're seeing, what they have is real. And so, yeah, I hear what you're saying about the downside of it. Yeah, they do have physiological changes, but pain is a complex matter.
Well, thank you for all of that info. And I think that this will definitely give therapists something to think about. It'll give therapists a great way to move forward with treatment. People now know how to access some clinical practice guidelines. And that leads me to the last question for you. And that is, knowing where you are now in your practice and in your life, what advice would you give to yourself as a new grad fresh out of physical therapy school?
I would probably recommend to take more time to reflect on my patients, not necessarily bringing them home, but to take a little more time to reflect on the things that they said personally related to their care, and also reflect on outcomes to a greater degree.
Great advice. I always say I would like to go back to my patients in my early days and just be like, I'm sorry. Sorry.
Right.
I was doing the best I could with the information at the time, but, of course, as you gain more knowledge, you gain more experience, you look back on things and you're like, oh man, I could have done that better. But that is part of that reflection process. So you look back on patients and you reflect and you think, maybe I could have done X, Y, and Z. So then the next patient comes along and you do better. So I think that's great advice. I love it.
Well,
and
thanks.
where can people find more information about AAOMPT and more information about you if they have questions or anything like that?
Oh, absolutely. So the AAOMPT website is www.aaompt.org. And you can certainly email me. I am at elonnemann@usa.edu. I'm happy to answer any questions or talk to you more about the Academy of Orthopedic Manual Physical Therapy, APTA, where to find guidelines, research on low back pain. It's just something I'm very passionate about and always enjoy talking about and working with patients with as well.
Awesome. Well, thank you so much. And thank you for coming on, sharing all this info. I appreciate it.
Thank you. I appreciate it.
Yeah, and everyone else, thank you so much for tuning in. Have a great couple of days and stay healthy, wealthy, and smart.
A huge thank you to Dr. Elaine Lonnemann, and of course a thank you to our sponsor, Net Health. And again, if you want to sign up and for a free opportunity to check in with the latest thoughts of other rehab leaders, check out the online rehab community designed for the intersection of clinical and business sides of rehab. It's the Rehab Therapy Operational Best Practices Forum. You'll see stats on community members already involved, plus some new polls just launched that I'd love for you to weigh in on. You can expect write-ups, white papers from leading-edge performers, polls, surveys, benchmarking calculators, videos, podcasts, and more. So jump in, subscribe, and join the conversations today. You can find the Rehab Therapy Operational Best Practices Forums at www.nethealth.com/healthy.
Thank you for listening, and please subscribe to the podcast at podcast.healthywealthysmart.com. And don't forget to follow us on social media.